Hi everyone, and welcome to the November Live Well Today webinar from the Davis Phinney Foundation. My name is Bo Baumer. I am a program manager here at the foundation, and I am delighted to be joined by neurologist Dr. Christina Swan. And we are going to talk about advanced, or what we might call next step therapies in Parkinson's. Our Live Well Today webinar series is sponsored by Amneal and Merz Therapeutics. We are grateful, so grateful to our partners for their support of this event and for their support of the Parkinson's community. Today's topic is advanced therapies. It can be a complicated topic with a lot of different pieces to it. So I think we'd probably better start with, what do we mean when we talk about advanced therapies or next step therapies? Let's first say what's in this category that we'll be discussing today.
Sure. As most folks will be familiar with, the basic approach to the treatment of Parkinson's when symptoms become bothersome is starting oral medications, the gold standard of which is carbidopa, levodopa, or Sinemet. Over time, as the disease changes the brain, the dose of medicine that's needed and how often the medicine needs to be taken in order to improve symptoms of slowness, stiffness, and tremor, it all increases. Despite very strict timing of medications, appropriate doses, patients can struggle with the feeling of the medicine ramping up a little too much and giving them extra wiggly movements called dyskinesia, and also the feeling of the medication leaving their body, which we call wearing off. And that constant interplay between high and low is what is termed a motor fluctuation. Now, that can be very burdensome. Folks are living by the clock, and it really can be quite a burden. And so what we mean by advanced therapies are different strategies that are available to treat the symptoms of Parkinson's that are not traditional Sinemet. So this could be extended release pills of levodopa, of which there are a couple new forms. This could be a pump, of which there are quite a few new ones that's delivering medicine continuously under the skin. Or this could be a surgical option. So those therapies would include deep brain stimulation and now focused ultrasound. I would consider all of those categories to be an advanced therapy.
And when do people typically start looking at this? You talked about off time and increases and fluctuations. Is that generally the point where people start saying, I need to look at what additional options are available?
That's a great question. So in general, I would say there are three rough groups of people who will start to inquire about advanced therapies at different time points. So the largest group are the people that are experiencing those motor fluctuations, those on and off, and dyskinesia. Those people will probably look for an advanced therapy later after they've had Parkinson's for a longer period of time, because it does take quite a long time to kind of get to that point when you're on medications frequently. The other group of folks that might present a little bit sooner there's a subset of folks with Parkinson's that have a rest tremor that really does not respond well to levodopa. For some people it does, for some people it doesn't, and it becomes very bothersome in their activities. They may not have as many problems with stiffness and slowness and walking, but that tremor is so disruptive that they may come to see me a little bit earlier in their total disease course. And then there is a very small group of people that have very severe side effects to levodopa on very low doses. So the balance between what they need to control their symptoms and what amount gives them side effects is disproportionate. So they'll come seeking some other strategy to treat their symptoms a little sooner in their disease course as well. The bottom line is when somebody feels like the symptoms they have are too bothersome with the way they're currently being treated, is the right time to start asking your specialist about what options are out there and if they could be right for you. But in general, those are the three categories of people that I see.
Well, I think we'll dig into these each one by one, and then we'll talk a little bit about informed decisions and making the right decision for you, because there are sometimes options. And then we'll certainly have time to take questions from the chat at the end of our conversation. So if you have questions, please share them there. We might get to a few over the course of the conversation, and then we'll catch some at the end. So let's start by talking about extended release medications. Can you walk me through the several options that are there for extended release levodopa?
Yes. Yes. So there are two newer forms. One of them has been around for several years. One is been around about a year, and those two are Rytary and they are Crexont. Both medications combine a quick release form of levodopa with a slow release form of levodopa, with the idea of trying to give a more sustained, even release of the levodopa into the bloodstream so patients don't have to dose as frequently. Um, Crexont is newer than Rytary. It's different because there's also a special coating on that capsule that allows it to stick to the gut. So if it's also physically staying in a certain place, the idea is that it can be in the spot where it needs to release longer as well, um, with the hope that it can cut down the number of times that people are dosing to maybe 3 or 4 if somebody's taking medicine, let's say every 2 hours during the day.
And the point that you made about the gut, that's maybe to remind people that in order for any of these medications to be effective, they have to travel from, if you take something orally, through into your gut, and it needs to be absorbed at that
Mhm.
point, and that can be a challenge uh, as a chemical process, right?
Yes. Um, One of the things that folks will probably hear about a lot from their specialist is the interplay between food and the medication. So protein in particular, the protein component of food, competes in the gut with levodopa for getting absorbed. So if there's protein there, you'll absorb maybe about, let's say, 70% of your dose. Um, when you've got special coatings on pills that allow them to stick around longer, to let that protein move through, and the drug's still there to get absorbed, the idea is that it's a little less food sensitive and you absorb the pill better. Um, some folks will feel the effect of protein more profoundly than others. Some may not notice it at all. For some people, they may even feel that their pill doesn't even work if they still have some food in their stomach when they take their pill. So that can be quite a significant factor for folks.
So you told me a little bit about the physical characteristics of Crexont
Mhm,
versus Rytary and how they're different.
mhm,
With that said, is
mhm.
there a right candidate for one or the other? Is there
Uh,
a particular profile of a person that's going to respond better to Crexont or that's going to respond better to Rytary?
that is an excellent question. And I would say that since Crexon's only been around a year, we're still figuring that out. And right now, honestly, it's coming down to which one insurance will cover better. I don't think we have the experience clinically yet to know which is better for what kind of patient. I have a lot of patients that have done well on Rytary for a long time, and I have a lot of patients that now like Crexont. Um, One thing we're trying to figure out is if there's a delay in how quickly one absorbs versus the other when you first start taking it. But honestly, once you're able to get somebody to an even blood level that's never dropping off, how long it takes the next dose to kick in, if it's slightly shorter or slightly longer, isn't something that a patient would notice.
How about side effects, limitations? Do
Right.
they differ between the two pills?
That's a great question. They don't, and they're very similar ultimately to regular carbidopa levodopa because at their base, that's what they are. So I would say the same side effects you could see if you're on a little too much levodopa, which would be dyskinesias or hallucinations would still be there. They're not more likely to happen with Rytary and Crexont than with Sinemet. I would even say that dyskinesia is often better with Rytary than Crexont because in general, the way we think about dyskinesia is it's not just related to the absolute dose of levodopa, but to the pulsing, the up and down. So if you are on a therapy that's holding your blood level more constant, you're not pulsing up and down as much, you can you can very balance out the gap between feeling that you have good on symptom control and peaking into dyskinesia.
One more question about these extended release pills, because I'm seeing some questions and comments in the chat about timing and about things like deep brain stimulation, which we'll be talking
Sure.
about later, and how that's become something that happens earlier.
Mhm.
Nevertheless, does it tend to be that extended release formulations of a medication that somebody is already taking are the natural first stop before considering some of the other options?
That's a great question. And I would say that one could operate under a framework of slow escalation in therapy. So the least invasive strategy up the ladder that works for that person. So if somebody is feeling that they're dosing their regular carbidopa-levodopa too frequently, trying Rytary or Crexont makes sense because if you can get an extra hour or two out of each dose, that makes a big impact on the daily schedule, the timing of meals, etc. Um, Certainly, somebody doesn't have to be on that pathway. If somebody's really interested in deep brain stimulation, you don't have to try those extended release therapies. And then keep in mind also that subset of people for whom levodopa just isn't controlling their tremor, Rytary or Crexont are not going to work any better because they're fundamentally the same drug. Um, so if somebody is interested in doing the most conservative thing that is a step up in therapy that helps their symptoms, then I would say trying Crexont or Rytary would make sense as a first step.
Okay, so let's now talk about infusion therapies, and we will eventually get to, again, some of those more complex treatments, deep brain stimulation and focused ultrasound. So stay tuned for those things. But there's a lot to talk about in infusion because, once again, we have new medications that I think people are still, they're arriving in the market and people are making use of them. So I think we want to talk first about Vyalev and Anapgo, and we might as well start with Vyalev. What is it? How does it work? Who's it best suited for?
Perfect. So Vyalev is the new product from AbbVie, which also were the producers of Duopa. So Duopa, for those who are familiar with that term, was the therapy that would give a continuous infusion of dopamine through a feeding tube in the stomach for 16 hours a day, and it was off overnight. And we saved it for really advanced cases where maybe surgery wasn't an option because, again, it involved surgical placement of a feeding tube in order to get the drug into the body. Ultimately, that drug is still going through the gut, so some of the same food issues would arise. Vyalev is, instead of delivering the drug into the gut, it is delivering the drug underneath the skin into the fat layer under the skin. It is directly absorbed from there into the blood, so it bypasses the gut entirely. And one could think of it, an analogy that comes up a lot when I'm explaining Vyalev in the office is the insulin pumps. So it involves self-application with an auto injector of a small little cannula that pushes a very tiny plastic tube under the skin into the fat that is connected to a pump that's worn often at the waist, and it will continuously deliver a phoscarbidopa, phoslevodopa solution under the skin for 24 hours a day. So it can be worn all day, all night. It has three different speeds at which it can push through drug into the body, a base rate that's used typically for normal daytime activities, a low that folks will turn down manually to sleep on, and a high if they're going to be out for an extended period of time, like, for example, playing golf or doing an exercise class at the gym. It also comes with the ability to give a quick rescue dose, which would be analogous to if somebody were having an off day and needed to take like an extra half tab of levodopa. The pump has a feature that can mimic that as well. So this therapy is good for people whose symptoms respond to levodopa, but again are struggling with the ons and offs, failed doses because of, let's say, food interactions, um, and dyskinesia. What it's doing is now, instead of mimicking as best we can with careful timing of medication, a continuous blood level of dopamine, it's actually forcing it to stay steady. It's a bit more physiologic that way when you think about what the brain is typically wanting, which is continuous access to dopamine, and it can smooth out levodopa responsive tremor, stiffness, and slowness. So because you never bottom out, it will significantly improve the motor fluctuations. And again, when you hold the blood level constant, you're also avoiding those peaks that trigger the dyskinesia. So it can help with that as well. Um, so for somebody for whom pills, let's say they've tried Crexont and Rytary and they're still fluctuating, still struggling with some dyskinesia, that would be a great next step. It's a little invasive, but it's just under the skin and self-applied.
What about the differences between Vyalev and Anapgo?
Yes. Onapgo in its mechanism of the self-injection wearing the pump is similar. Onapgo is an entirely different drug. So Onapgo is apomorphine. Apomorphine is a dopamine agonist. Um, Other dopamine agonists that you might be familiar with are pramipexole and ropinirole, but it works very differently. It actually used to be around in the 60s. It predated carbidopa levodopa for the treatment of Parkinson's, but the problem with it is that its half-life is way too short. It's 15 minutes and it starts wearing off. So that's why it's not around in any sort of a pill form. But again, if you have a continuous delivery, the fact that the drug is breaking down quickly doesn't matter. It will work similarly to levodopa in terms of how it modulates the brain. It can only be used for 16 hours a day. It is turned off at night. It can also result in reducing medication. So one thing we didn't talk about is that when you start Vyalev, because it is levodopa, it's what that drug turns into directly, you can stop all your oral Sinemet and entacapone, rasagiline or selegiline right away because it's a direct conversion. Onapgo, because apomorphine is a new drug, people don't tend to stop their oral pills right away, but they can wean down on them quite significantly. That's a process that takes a little bit of time, and then they might need some pills at night when you turn that pump off. So it's a bit different in how quickly it kind of impacts the daily routine, and it's not levodopa, so people do tend to still need some pills, but it's often less. And again, because you can wean your oral pills, it can improve dyskinesia. And if the pump is doing more of the work than the pills, then that on-off fluctuation should improve as well.
Now, we had a question in the chat.
Mhm.
Should adopting an infusion therapy, I think expectation setting is important. This isn't going to necessarily lead to the elimination of all off times.
No. So that is a very good question. Even on a 24-hour therapy that is theoretically continuous, the brain still fluctuates in Parkinson's. People will still have on and off days, which folks will experience now on their pills. And we don't know exactly why. And that's why these pumps come with these rescue doses, these multiple rates to allow somebody to adjust on the fly to make up for those times when they're feeling a little more off. I will say that the offs are much gentler on these kinds of therapies than on the pills.
Can you say a little bit more about that?
Yes. So, um, as the pills are leaving the system and you're waiting for the next one to kick in, your brain is coming much farther down in terms of the amount of dopamine that it's seeing as opposed to the pump. So the pump does bypass the gut, but one thing that we should mention is that it's not entirely food insensitive. So what I mean by that is it's true that it's not going through the gut, it's getting straight into the blood, but the barrier between the blood and the brain has another receptor that is protein sensitive. So people can feel a fluctuation with food still with the pump, but because there's immediately more drug coming right behind it, it doesn't feel like as much of a drop as it does with the pills. And another strategy that I found effective for folks that feel still a little food off on the pump is to push a rescue dose right when they're starting their meal. So they have a rescue coming up in the blood as what's there is dipping down a little bit to kind of keep people even.
So let's go back to Duopa really quickly, just
Mhm.
because in hearing what the new technologies are, obviously they're new, they are rolling out. But what's the case for Duopa now? Like, are many people, will there be very many new Duopa patients from this point on, or will there be an evolution in this area?
That is a great question. I think that Duopa will still have a role. I think that role will shrink to someone who couldn't do a surgery, somebody who really needs a continuous therapy, but also somebody who couldn't or their caregiver couldn't manage the daily maintenance that comes with Vyalev or Onapgo. Um, there is daily site maintenance and daily reloading of the pump that comes with Vyalev and Onapgo. With Duopa, the pump site, once the tube's in place, the tube is just there. You don't change it. You change those pumps, the feeding tubes out maybe every couple of years, but there's no local site maintenance that needs to happen. It's just reloading a new cartridge into the pump. So it's a little bit easier in that regard. Um, and with Duopa, it's less likely that that site where the tube is located is going to get a local skin infection. With these infusion pumps, because there's always a little port going right under the skin to outside of the body, there is a risk of a local skin infection, which is why there's a lot of strict training on hygiene and why the site has to be moved every few days.
Two more questions,
Hmm.
and then I want to turn to deep brain stimulation.
Sure.
The first one is somebody asked in the chat, Kevin asked in the chat, what
Hmm.
happened to Imbrija? Now that, because you've talked about rescue meds, and I know we're hopping backward a little bit here to talk
Hmm.
about a different kind of medication, but since that was designed as a
Hmm.
rescue therapy, does that mean that because there are now maybe more rescue therapies available, that there will be fewer people using that drug, or does it still appeal to different kinds of folks?
Right. Great question. So that will still be a useful therapy. And I do think the emphasis is on the rescue part. So for people who are doing pretty well on their oral pills, but every so often a dose doesn't kick in the way that it should, or in the morning for whatever reason, some people's first dose of the day takes a long time to kick in. Inbrija is helpful. What that is it's like an inhaler. You put a capsule that has some levodopa powder inside, crush it, and breathe it in. It should kick in within about 15 minutes, and it only lasts about 90 minutes. So it's really designed to just turn you on while medicines are trying to kick in. That still has a role, and it could even still have a role even if somebody were on Rytary and Crexont. If somebody were on the infusion therapies, I would imagine it would have less of a role because, again, there's rescue features on the pump. Um, Other rescue therapies that are still out there is something called Apokin, which is an self-injectable. That is actually apomorphine. It's, I think, the only commercially available form that apomorphine exists outside of Onapgo. So I guess I would boil it down by saying that for somebody who is still on a lot of oral medications, the rescue therapies are helpful. On the pump, it would be less helpful, but folks with DBS, which I know we're going to talk to next, are often still on medicine. So Inbrija or any rescue therapies would still have a role, though ideally less often once DBS is in place.
Last question on this topic, because it's come up several times in the chat,
Mhm.
and I know you can't necessarily answer in terms of specifics. So
Sure.
maybe generally, we're getting questions about insurance and cost here.
Oh, yeah.
And you may not know whether, perhaps you know whether the large, like Medicare or TRICARE, for instance, because those are so large, you may have dealt with them, what how they're looking at these. But generally speaking, these are still new therapies.
Hmm.
Will it take insurance some time to catch up to the medical field in this area, or how does that tend to work?
Yeah, that's a very good question. I get it a lot. Commercial insurances are by and large, so like your Aetnas, your Cignas, United Healthcare, et cetera, are paying for the pump. As of August, Medicare is paying for it too. And Medicare plus a supplement is turning out to be very, very affordable for folks. So I have started enrolling Medicare patients successfully in the last couple of months. Medicare Advantage plans are different depending on who the underlying insurer is, but some Medicare Advantage plans actually started paying for the pump 6 months ago, so months before regular Medicare did. So I would say if you're curious, in the last 3 months, I have had a lot of success with new enrollees across the spectrum of insurance plans.
I'm glad that we asked that because
Yeah.
it's
And not
something
everybody
everybody has to
knows.
negotiate.
Yeah, not everybody knows that Medicare has started to pay for the pump. And again, Medicare plus supplement, since I think it's still technically open enrollment, the supplement tends to cover that last 20% after Medicare covers the first 80%.
Well, now let's turn our attention to a couple of other advanced therapies. And the first one is deep brain stimulation. Now, we talk a lot about DBS at the Davis Phinney Foundation, but I know that with 350 people on board for this webinar, there are going to be people who are learning about this for the first time. So, can you start by telling me, because it can be kind of an intimidating phrase, I think, if it's the first time you've heard it,
Mhm.
what is deep brain stimulation? How does it work?
Sure. So deep brain stimulation, what we do is we drill a small hole on each side of the brain and place a very small wire down into a deep part of the brain in the area of the brain that we think is largely responsible for the symptoms of Parkinson's. That wire is connected to an extension cable that all runs under the skin and behind the ear to a pacemaker-like battery in the chest. We then use electrical impulses coming from the battery into the brain to control symptoms of tremor, slowness, and stiffness. It is a therapy that will run all the time in the background and start doing the lion's share of the symptom control. And so, again, because now you have a continuous therapy in the background, folks don't feel like they fluctuate. And it allows us often to wean meds down so dyskinesia can improve as well. It will work. Generally, we say that you can think about DBS if you think about the best you feel on your medicines stretched out all day. That is how we describe the effect of the DBS, with the caveat that it will also treat a levodopa unresponsive tremor. So again, that's a reason why those folks might seek DBS out earlier.
It's obviously has been a game changer, and as we were intimating a little bit ago, it has gone maybe over time from this is a last resort, this is on the cutting edge, and it's still obviously an advanced and fascinating medical therapy, but it's there have been hundreds of thousands of DBS surgeries performed now, and people are looking at it sooner than later sometimes. Can you talk a little bit about timing?
Yes, I would say that on average, folks, again, it depends on who, what their symptom is that is bothering them. If it's motor fluctuations or tremor, let's say. On average, we want people to have been diagnosed with Parkinson's for at least 5 years before we think about deep brain stimulation. Folks with motor fluctuations are often coming in maybe around the 7 to 10 year mark, let's just roughly speaking, because there are a lot of different medications on the market, extenders for levodopa, now the slow release, now the pumps that people may want to try before they think about DBS. I would say that because it is an invasive treatment, that's probably more of a reason why it tends to be pushed to later, because that's something that should make anybody a little nervous, that make sure that it's the right decision for them. Folks with tremor are more likely to medication unresponsive tremor are more likely to present closer to that, let's say, 5-year mark. Once we're really sure we've done everything we could do outside of an advanced therapy to try and suppress the tremor.
So, are there people who ultimately are not the best candidates for DBS? And then, can you also talk a little bit more about some of the potential risks? Although I
Yes.
know we're working, for instance, on editing of the Every Victory Counts manual, the new edition that's coming out next year. And I read that the risk rates are very low and comparable to other kinds of surgeries that people tend to get later in life or at certain points in their life. So, can you talk a little bit about that?
Yes. I would say that we will consider people for deep brain stimulation. So, at least for us, and it will vary by center and by surgeon, but I can speak from our experience. So, age is not so much a cutoff for us, though generally I would say folks under 80. Um, People that do not have any significant issues with their thinking and memory, and I'll come back to why when I touch on the risks of the procedure. And people who are medically healthy to undergo this type of procedure. So, folks that maybe have severe heart issues, for example, or other severe organ issues. It just may not be safe to do surgery on them in general. In terms of the risks, there is a workup process that we tend to do to determine if somebody is a candidate or not. And I'll explain the risks first, and then it'll make sense why we do particular screening tests. So anytime you open up the brain, there's a small risk of infection, I would say less than 1%. Anytime you push something into the brain tissue does a good job of moving to the side because it's like jello in water. But there is a small risk of bleeding. The risk of any significant sized bleed is less than 0.5%. Now, I mentioned that the part of the brain where we're trying to put the wire is down deep, but your higher order thinking and processing brain tissue sits on the top. So when you push through it, there is a small risk, I'll call it 2 or 3%, that somebody feels not quite as mentally quick as they did before or has a little bit of issues with word finding. So, in order to help decide if somebody's a candidate or not, everybody gets baseline memory and thinking testing, which is a pretty rigorous battery of tests that look at memory, language, visual spatial processing, etc. In terms of memory and thinking, there's 3 zones, roughly speaking. There's normal, there's what we call mild cognitive impairment, which means, well, you're not as sharp as you used to be, but you're perfectly well functioning and independent. And most people get into that zone just by nature of age anyway. And then there's dementia. So sometimes people can be functioning really well, but score closer to that borderline of dementia. And who knows when they would get there, but the point is there's not a lot of buffer than we would like. And because we're very cautious, even that 2 to 3% risk might make us nervous that we sort of tip them cognitively when we're trying to make quality of life better. So that's a conversation that we have, and it might be a reason why we don't get all the way through to surgery. We will do an MRI of the brain under anesthesia. And so if there's any structural issues, any really complicated vessels that are a bit abnormal and unique to that patient, something in the way we don't expect, where we think it would be a higher bleeding risk, that would be another reason why we wouldn't do it. But otherwise, I would say we don't tend to exclude people for other reasons, at least from the workup.
Monique asked in the chat
Uh-huh.
something similar to the question we had before.
Uh-huh.
This doesn't mean that we can assume that with DBS, suddenly you have no off time at all, or what does it mean?
That's great. No, so Parkinson's fluctuates, which is frustrating for patients and the folks trying to take care of them alike. It is true that there will still be good days and bad days. Similar to the infusion pump, the lows are not quite so low because there is that background continuous therapy that's giving you something. But when you think about it, there can be a lot of reasons why somebody has an off day. It could be poor sleep. It could be a head cold. It could be a urinary tract infection. It could be a life stressor. And we don't always know how to pinpoint exactly what the trigger was, but it is true. No matter what we do, folks will still feel like they fluctuate a bit. One of the interesting things about deep brain stimulation to address how to do even better with those fluctuations is Medtronic's new tech, which has been around for about 6 months commercially. And what their wire in the brain does that is unique is it records what the local brain cells are doing. And so it can track when there are highs and lows in the local brain activity and automatically adjust the strength of the stimulation to account for that, with the entire goal of trying to do even better than standard DBS for smoothing out fluctuations, and doing better for walking as well. So that's very interesting. We're starting to use it. I would say again, just like with Crexont, it's too new um, to say for sure how dramatic of an impact it's having, but I do have some experience with it, and I do think it's really helped a couple of patients. So it's exciting that even though DBS has been around for 30 years, they're still innovating with new and improved tech.
Many, many questions about DBS in the chat, and I hope that we will be able to get back to several of them at the end. But
Okay.
there is one more area that I wanted to talk about, and that is focused ultrasound. So, kind of
Yes.
let's start at the beginning as we did with DBS. What is it? How does it work?
Yes. Okay. So focus ultrasound, what is happening is they are shooting high intensity sound waves all around your head while your head is in a frame and you're in an MRI machine. And all of those beams will meet at a tiny little point deep down in the brain and burn a hole in a very precise spot. The idea for this goes way back to before DBS when they used to do the same thing, burn a hole in a particular spot, but they'd have to drill a hole and push a special wire down in order to do it. So now this is the same concept, but incisionless and without damaging anything along the way to the spot that you actually want to lesion. And the reason why we do this is because we have seen that it can help symptoms of tremor and also motor fluctuations and dyskinesia. Now, the tremor spot has been around a bit longer, it's got to be coming up on 6 years now. The newer spot, which was very recently approved to do on both sides of the brain for motor fluctuations and dyskinesia, is an intriguing option for people with uh, motor fluctuations and more advanced stages of Parkinsonism as well. But sort of the field experience with it is less because it just got approved to be done on both sides. So the tremor spot of if we treat with focused ultrasound, will treat only tremor. It will not treat slowness, stiffness, or walking. The other thing to keep in mind is that when you burn a hole in the brain, you have to be very careful that you don't clip anything else surrounding the spot where you want to go. So, for example, if you're doing the tremor-based focused ultrasound procedure, the tremor spot is right next to the spots for balance, speech, and taste. So if the hole is a little bit off, somebody could have a little bit more trouble with their balance than before, or have a very mild speech slurring, or have a little bit of issues with taste. Once the hole is burned, it can't be undone. And at least in tremor so far, since that's been around long enough for us to see this, eventually the tremor finds a way around the hole that you burn. You can't expand the hole, and we don't know if you can put a hole in another spot after that yet. So it's a procedure that we tend to consider for folks that are older, since this may eventually wear off, and for folks that wouldn't be able to tolerate brain surgery because the treatment so far seems a bit less durable than something like DBS, which has electricity settings that you can adjust over time. Now, the other spot that is now approved for motor fluctuations and dyskinesia, it does work well. We don't know how long the benefit will last. That's a big unknown. And there is a risk of clipping nearby structures as well. So people can have trouble with balance and a little trouble potentially with some motor weakness on the side that's treated. I would say the risk of these side effects across the board tends to be pretty low. So let's say around 5%. So odds are folks would go through the procedure without a permanent side effect, but focus ultrasound is something we really I spend a lot of time harping on these side effects because even if the risk is small, somebody has to be okay with the risk of that permanent side effect and the procedure eventually wearing off. Because you have to think about, well, then what comes next? So in my personal practice, I tend to save focus ultrasound. Again, for folks who are older, where DBS is not an option, and we are all okay with um, what life might look like if we do get that low risk of a side effect.
Two more questions, and then I
Uh,
think I'll turn fully to the chat. The first one is, are we talking about people who are out there deciding, is DBS the right path for me, or is focused ultrasound the right way? Is that a common place to land? And what are some of the things people are really ultimately putting down on the pros and cons list at that point?
yes, I would say that when folks come to my office, we are constantly comparing and contrasting what one or the other can do for them. Um, And some people, when they initially come, they ask me about focus ultrasound because they don't like the concept of drilling holes. Um, and that's why I spend a lot of time talking about, okay, how many years of benefit are you hoping to get out of this treatment? Um, what is your baseline balance really, really good? Could you tolerate it if you got that small risk of a balance effect? And we kind of compare and contrast what those small but possible scenarios could look like to decide, okay, well, I'm actually okay with that, what life looks like, or okay, maybe I do want to think about the more durable treatment because I'm 65, even though the concept is a little scary. Because it's really frequent that we pair people with our psychologists as well to kind of do some counseling, to do some meditation training, to help them get through that experience if they would find that to be helpful.
So obviously you've talked there about some of the things that you as a in practice are walking people through.
Mhm.
I would imagine that sometimes somebody ultimately comes to a different conclusion from what their doctor might decide.
Yep.
Can you tell me a little bit about what people should be thinking as should they be seeking second opinions? What should they be factoring in what their care partner and what other members of their care team are talking about? Obviously,
Mm.
several people on a care team are weighing in
Yes.
ahead of something like DBS. So just for people who maybe are arriving at a decision point that they're still not totally confident in,
Mhm.
or that they're disagreeing with maybe or having a difference of opinion with somebody on their care team, what happens then?
Yes, that's a great question. I would say that if the patient and the care partner are aligned and um, they clearly fully understand the benefits, but also the risks of a procedure, and they want to pursue it, and we've thoroughly talked through the other option, I will respect that decision. If they say, Dr. Swan, I hear you, I accept the risks, I want to do this, I will say okay. Because that's my only job is to make sure that the patient is fully informed and just to help you make the choice, not to make the choice for you. It's tricky when the person seeking treatment and their care partner disagree. That's a tricky position to be in as a provider in general. Um, and I spend a lot of time getting at the root cause of what the caregiver is hoping for and what the patient is going for, seeing if there's a knowledge gap that I can help correct that might influence one decision or the other. But I do welcome multiple opinions. At any time. I think that no matter what you do when you're thinking about a surgical option, it is doing something permanent to your brain that can alter life in a good way, odds are, but there is a chance of a bad way. And so my personal perspective is take all the time you need, ask all the people you want to ask, and if you disagree within your family unit, let's have as many appointments as we need to get to the root cause of why and how I can help. I try not to be too heavy-handed. And I would encourage other providers to be the same, but sometimes you do get asked, well, what would you do? So at the very least, I just always try to make sure that the rationale, pros and cons are clear. And then we see how the situation evolves from there.
Okay, we've got about 10 minutes left, which is great because folks are asking many different things. And one thing that's come up in the context of DBS and then more broadly is freezing of gait. So
Mhm.
is DBS effective with freezing of gait? Are other advanced therapies better, more or less useful in that area?
Amazing question. Freezing of gait is notoriously a difficult symptom to treat in Parkinson's in general. In a lot of people, it is initially responsive to levodopa, which means it will be responsive to DBS as well. At some point, it stops responding well to whatever treatment you throw at it. Part of the idea for Medtronic doing this adaptive DBS was to see if it can do better for freezing. I would say anecdotally, it may, but time will tell. Similarly, with the Vyalev infusion pump, in theory, it's just levodopa, so the rule I said should apply. However, anecdotally, I have seen patients feel that on the continuous therapy, freezing is better than it was on best oral meds. And the reason for that could just be not that there's anything different about the pump, but it's again that continuous exposure to a therapy and not this complex waxing in and waxing out of oral pills. So nothing, unfortunately, is the secret weapon for freezing, but I would say that the advanced therapies can help to a degree um, beyond the pills. And most likely that has to do with one being reliant on the gut and the other not.
We haven't really talked much about non-motor symptoms in these
Mm,
contexts. So do you want to say a little about that? I was just thinking how you were saying anecdotally we see this and that
yeah.
response, and I thought, well, maybe that's because some of these therapies produce at least a temporary effect, if not a permanent effect, that creates more peace of mind, less anxiety because of improvements. But that's me speculating, and I would like the doctor to weigh in on this.
Yeah, I would say in general, the mood effect in relation to Parkinson's and its treatment is complex. In and of itself, Parkinson's will ramp up mood and anxiety separately from how well someone is coping with having this diagnosis in general. These treatments don't really treat non-motor symptoms, but if somebody feels like they have better control, as you said, mood and anxiety may improve because they feel better overall. Um, no therapies really improve speech. I've seen some people feel like their swallow picks up a little with the pump and DBS, but again, that just may be because of a little bit better coordinated motor control with the swallow. Um, but I would say that in general, we don't really expect the non-motor symptoms, which we think of as drooling, swallowing, memory and thinking, or mood, to be affected by these therapies.
People are asking about DBS and
Hmm.
timing, and
Hmm.
can it be sooner than 5 years? Some people I know say 4 years, but what are some of the reasons why you can't do it you know, 6 months after diagnosis. I understand one of them is you might end up with a different diagnosis after a period of time. Is
Right.
that part of it? And are there other things that you're thinking of?
Yes. Um, Great question. The 5 years is more kind of a general literature recommendation. Could we consider somebody at 4? We could. You did hit on a couple of good points. Um, in general, we want to make sure the diagnosis is correct. There can be what we call atypical Parkinsonisms that look like regular Parkinson's disease in the beginning, but then evolve over time to early issues with falls, early issues with really significant swings up and down in blood pressure. We know from studies that deep brain stimulation does not help people with atypical Parkinsonisms, and so we don't want to put somebody through the risks of surgery if it's ultimately not going to help. The other reason why, I would say that medication refractory tremor is an exception. So that might be a case where we do it a little sooner because we don't have good treatment options otherwise. But we want to make sure that somebody is responding to levodopa and that it's been tried. Because in general, we want to do the most conservative treatment that has the biggest impact for people. Um, and they've looked at studies where they've implanted DBS early in Parkinson's course, and it didn't really seem to have any greater benefit than implanting it, let's say, after 5 years in terms of people's overall course. Um, and one of the important workups for deep brain stimulation so that we get a sense of how much it will help people is what we call a levodopa challenge test. So if somebody comes in totally off medicines, we give them levodopa and we see how significantly their symptoms improve. Because if it only improves like a little bit and their symptoms are pretty significant, we might be more suspicious for an atypical Parkinson's. So the medicines are actually diagnostically helpful, and they're also a useful tool for us to be able to show people, here's your best on, picture this, but not wearing off. Because a lot of people will ask, well, what can it do for me? And that's sort of the best way to give them the analogy in advance or the example in advance.
There are many questions about specific symptoms, and I'm going to try to get to three. And maybe
Okay.
you can give me some rapid fire thoughts on all of
Yes.
the therapies. The
Sure.
first one is balance. Where
Yes.
do we see the most improvements with balance?
So if balance is due to freezing, which it often is, then I would say dopaminergic therapies can help. And if it responds a little to dopaminergic therapies, it will respond to DBS. If balance is an issue, focused ultrasound is not the best idea. If balance is I lean over and then I can't get my sense of gravity and I fall, there's no real treatment for that right now.
The next one that folks have asked about is constipation.
All of these dopamine therapies that I am talking about, and even regular carbidopa levodopa, are trying not to deliver dopamine to the gut because that makes people very nauseated and ill. There is loss of dopamine cells in the gut, which slows the gut down and leads to constipation. But I would say these advanced therapies that I have discussed would not help that symptom.
And the last one I'd like to ask about, because it is how we spend a third of our time, is sleep.
Ah,
There are no easy symptoms with Parkinson's, but
right.
each one is complicated, and I'd imagine there are a lot of complications with introducing these new therapies and sleep.
Yes. I would say that the ones that are most likely to improve sleep are the Vyalev and the DBS because they're 24-hour therapies. Sleep, there's so many things that go into sleep, but if there's stiffness, if there's tremor, and the stiffness can be just a subtle, I can't get comfortable, um, it it has been shown in the clinical trials to improve when people have continuous low-level dopamine stimulation at night on the pump, and with DBS when they have sort of that continuous electrical stimulation in the background. Um, the extended release therapies um, can help with sleep some if they last a bit longer into the night. ONAPGO is not used at night, so that would not help. Focused ultrasound, I don't know yet, I'll be honest. It's for the motor fluctuation target, it's just too new.
Well, speaking of new, that leads me to my last question. This very webinar would have been so different, 16, 18 months ago because several of the therapies that we've talked about were not
Yep.
yet approved. This is also new 2024, 2025 approvals. With that in mind, what are you looking for in the future? What is giving you hope about the horizon of advanced therapies in Parkinson's right now?
Yes, I'm very excited for a couple things that are still in clinical trials, so we don't know if they work, but are trying to actually get at the root biology of what's going wrong in Parkinson's, and those are gene therapies and stem cell therapies. So there are some exciting trials that are probably just opening for recruitment now at centers across the country where they're trying to transplant dopamine neurons back into the brain, and they're trying to alter genes in dopamine cell areas of the brain to support the ones that are there and maybe promote a little bit of regrowth. And I think it's a really, really exciting time to be in this field because I think there's a lot of hope on the horizon. It's taken so long to even get to this stage. I think it's very encouraging, and I look forward to what the next 5 to 10 years are going to bring.
That's it for November's Live Well Today webinar. Thanks so much for joining us, and be well so long.
Thank you so much.